10 questions. Lung volumes and capacities. Pause after each question if you need time to think. Let's go. Question 1. Which lung volume cannot be measured by simple spirometry? A. Tidal volume. B. Inspiratory reserve volume. C. Expiratory reserve volume. D. Residual volume. Pause if you need to think. The answer is D. Residual volume. Here's why. Spirometry measures what you can breathe in and out. Tidal volume, the volume of each normal breath, you breathe it in, you breathe it out. Spirometry measures it. Inspiratory reserve volume, the extra volume you can breathe in above tidal, you breathe it in. Spirometry measures it. Expiratory reserve volume, the extra volume you can force out after a normal exhalation, you breathe it out. Spirometry measures it. Residual volume, the air that remains in the lungs after maximal expiration. You cannot exhale it. No matter how hard you try, it stays. Because spirometry only measures what you can move in and out, and residual volume never moves out. Spirometry cannot measure it. To measure residual volume, and therefore FRC and TLC, which both include residual volume, you need indirect techniques. Helium dilution. The patient breathes a known concentration of helium. It equilibrates with the gas in the lungs, including the residual volume, and the dilution is measured. Nitrogen washout. The patient breathes 100% oxygen. Nitrogen is washed out and measured at the mouth. Total nitrogen exhaled reflects total lung volume. Body plethysmography. The patient sits in an airtight box. Pressure changes with breathing. Total thoracic gas volume, including residual volume, is calculated using Boyle's law. Board pearl. Residual volume, FRC and TLC, all include residual volume. None can be measured by spirometry alone. Question 2. Physiologic dead space is defined as A. Air remaining after maximal expiration. B. Conducting airway volume only. C. Volume not participating in gas exchange. D. Maximum volume inspired after tidal breathing. The answer is C. Volume not participating in gas exchange. Here's why. Dead space is ventilation without perfusion, or ventilation of areas where no gas exchange occurs. There are two components of physiologic dead space: anatomic dead space, the conducting airways, trachea, bronchi, bronchioles, down to the terminal bronchioles. These airways conduct air but have no alveoli. No gas exchange occurs here. Approximately 150 milliliters in 70 kilogram adults. The classic estimate, 1 milliliter per kilogram body weight. Alveolar dead space, alveoli that are ventilated but not perfused. Normal alveolar dead space is minimal in healthy lungs, nearly zero. But in disease states, pulmonary embolism, air embolism, hypotension, alveolar dead space increases dramatically. Alveoli are receiving air, but no blood is arriving to participate in gas exchange. Physiologic dead space is the sum of both, anatomic plus alveolar dead space. The Bohr equation estimates physiologic dead space, using the difference between arterial and expired CO2. Clinically, increased physiologic dead space means you need to ventilate more to achieve the same CO2 elimination. This is why patients with massive PE or severe lung disease require higher minute ventilation. A large fraction of each breath is wasted on dead space. And in anesthesia, intubation bypasses some anatomic dead space, but the circuit adds dead space of its own, particularly with mask ventilation and certain breathing circuits. Know the components. Know the clinical implications. Question 3. FEV1 is defined as A. Total air exhaled after maximal inspiration. B. Volume exhaled during first second of forced expiration. C. Volume remaining after expiration. D. Maximum inspiratory volume. The answer is B. Volume exhaled during the first second of forced expiration. Here's why. FEV1, forced expiratory volume in 1 second. The patient takes a maximal inspiration to TLC, total lung capacity, then exhales as hard and fast as they possibly can. The volume that exits in the first second is the FEV1. This single measurement tells you a tremendous amount about airway function. In a healthy young adult, FEV1 is approximately 3 to 4 liters. The first second captures the majority of the forced vital capacity, because in healthy lungs, expiratory flow rates are high, and most air is expelled quickly. In obstructed airways, asthma, COPD, expiratory flow is limited. It takes longer to move air out. FEV1 is reduced because less air exits in that critical first second. FEV1 is used to diagnose obstructive lung disease, quantify severity, monitor disease progression, and predict perioperative respiratory risk. For anesthesia boards, FEV1 is also used in preoperative assessment for thoracic surgery. FEV1 predicted postoperative, less than 800 milliliters, significantly increased risk of respiratory failure after lung resection. First second, maximum effort, airway function in one number. Question 4. Normal FEV1 over FVC ratio is approximately A, 0.4, B, 0.6, C, 0.8, D, 1.0. The answer is C, 0.8. Here's why. The FEV1 over FVC ratio, also called the Tifano index, is the most important single number in spirometric interpretation. FVC, forced vital capacity, the total volume exhaled from full inspiration to complete expiration. In a healthy adult, approximately 80% of the FVC is exhaled in the first second. FEV1 divided by FVC equals approximately 0.8. This ratio is what distinguishes obstructive from restrictive lung disease, and this distinction is critical on boards. Obstructive disease, asthma, COPD, emphysema, the airways are narrowed. Expiratory flow is limited. FEV1 falls more than FVC. The ratio decreases below 0.7. Less than 70% of air exits in the first second. Restrictive disease, pulmonary fibrosis, obesity, neuromuscular disease, the lungs are small. Both FEV1 and FVC decrease proportionally. The ratio is preserved, often normal or even elevated, because even though less air is available, what is there exits quickly through normal airways. The FEV1 over FVC ratio, less than 0.7, obstruction. Normal or elevated, restriction. One ratio, two completely different diagnoses. Every board exam, every spirometry report. Question 5. Which pulmonary disease classically causes a decreased FEV1 over FVC ratio? A. Pulmonary fibrosis. B. ARDSC, restrictive lung disease. D. Asthma. The answer is D. Asthma. Here's why. A decreased FEV1 over FVC ratio is the hallmark of obstructive lung disease. Asthma causes airway inflammation, bronchospasm, airway wall remodeling, mucus plugging. All of these narrow the airways, increase expiratory resistance, limit the rate at which air can exit the lungs. The first second of forced expiration is dramatically curtailed. FEV1 falls, but the total volume of air in the lungs, FVC, is relatively preserved or even increased in severe asthma from air trapping. FEV1 falls significantly. FVC falls less or stays the same. The ratio decreases below 0.7, obstructive pattern. And critically for anesthesia boards, asthma is the prototype of reversible obstruction. After bronchodilator administration, albuterol, ipratropium, FEV1 and FEV1 over FVC improve significantly. A 12% improvement in FEV1 after bronchodilator is the spirometric definition of significant reversibility. Pulmonary fibrosis and ARDS, restrictive patterns, small volumes, preserved or elevated ratio. Asthma, obstructive, decreased ratio, reversible with bronchodilators. Question 6. Functional residual capacity is best described as A. Air remaining after maximal inspiration. B. Air remaining after tidal expiration. C. Air expired after maximal inspiration. D. Air inspired above tidal volume. The answer is B. Air remaining after tidal expiration. Here's why. Functional residual capacity, FRC, is the volume of air remaining in the lungs at the end of a normal passive tidal exhalation. Not maximal exhalation, not maximal inhalation, just normal relaxed breathing, end of a normal breath out. The word functional is key here. FRC represents the resting equilibrium point of the respiratory system, the point at which the inward elastic recoil of the lungs exactly balances the outward recoil of the chest wall. No active muscle contraction, just passive equilibrium. FRC equals ERV plus RV, expiratory reserve volume plus residual volume. FRC is approximately 2.5 liters in a healthy adult in the upright position. And FRC is the most clinically relevant lung volume in anesthesia. It is your oxygen reservoir. During apnea, the oxygen stored in the FRC is what sustains the patient while you are securing the airway. Larger FRC, longer safe apnea time. Smaller FRC, faster desaturation. This is why everything that reduces FRC, obesity, pregnancy, supine position, general anesthesia, reduces the safe apnea window. And this is why pre-oxygenation matters. You are filling that FRC reservoir with pure oxygen, maximizing the time available before desaturation occurs. FRC, resting equilibrium, oxygen reservoir, the most important lung volume in anesthesia. Question 7. Which condition increases functional residual capacity? A. Pregnancy. B. Supine position. C. General anesthesia. D. Emphysema. The answer is D. Emphysema. Here's why. FRC is determined by the balance between two opposing forces. The inward elastic recoil of the lungs. Lungs want to collapse, pulling FRC down. The outward recoil of the chest wall wants to spring outward, pushing FRC up. FRC is the equilibrium point between these two forces. In emphysema, the alveolar walls are destroyed. Elastin fibers are lost. The lungs lose their elastic recoil. They no longer pull inward with normal force. The outward chest wall recoil is now relatively unopposed. The equilibrium point shifts outward. FRC increases. Air trapping occurs. The lungs are chronically hyperinflated. Barrel chest develops, the visible clinical manifestation of chronically increased FRC. Now, every other option on this question decreases FRC, and this is critical for anesthesia boards. Pregnancy, the gravid uterus pushes the diaphragm cephalad, reducing FRC by up to 20%. Supine position, the abdominal contents compress the diaphragm. FRC decreases by approximately 500 to 800 milliliters compared to standing. General anesthesia, loss of muscle tone. The diaphragm shifts cephalad. FRC decreases by approximately 400 to 500 milliliters within minutes of induction. 3 things that decrease FRC. 3 reasons your anesthetized, supine, pregnant patient desaturates fastest of all. Emphysema increases FRC. Everything else on this list decreases it. Question 8. Functional residual capacity is greatest in which position? A. Standing. B. Sitting. C. Prone. D. Supine. The answer is A. Standing. Here's why. Position has a profound effect on FRC, and this effect is driven by gravity and abdominal mechanics. In the standing position, gravity pulls the abdominal contents downward, away from the diaphragm. The diaphragm sits at its lowest position. The chest wall can expand maximally. FRC is at its highest, approximately 2.5 to 3 liters. As you move from upright to recumbent, the abdominal contents can no longer fall away from the diaphragm. They press against it from below, pushing it cephalid, reducing thoracic volume, reducing FRC. The hierarchy from highest to lowest FRC: standing, highest; sitting, slightly less; prone, further reduced; supine, lowest. In the supine position, FRC is approximately 500 to 800 milliliters less than in the standing position. For anesthesia, this matters enormously. Most surgical patients are in the supine position. General anesthesia further reduces FRC by an additional 400 to 500 milliliters. Combined, supine plus anesthesia, FRC can be reduced by nearly 1 liter compared to the awake standing patient. 1 liter less oxygen reserve. 1 liter smaller safety margin. One reason obese, pregnant, and critically ill patients desaturate so rapidly at induction of anesthesia: their FRC is already compromised before you give a single drug. Standing to supine, FRC falls every step of the way. Question 9. Which factor increases functional residual capacity? A. Decreased lung compliance. B. Obesity. C. Decreased lung elasticity. D. Cephalad shift of diaphragm. The answer is C. Decreased lung elasticity. Here's why. Return to the fundamental balance that determines FRC. Inward recoil of the lungs, opposing outward recoil of the chest wall. FRC is where they balance. Lung elasticity, the tendency of the lungs to recoil inward, is the inward force. When lung elasticity decreases, as it does in emphysema, the inward pull is weaker. The chest wall outward recoil is relatively stronger. The balance point shifts outward. FRC increases. This is the mechanism of hyperinflation in emphysema: lost elasticity, reduced inward recoil, outward equilibrium shift, increased FRC, air trapping, barrel chest. Now the opposite: increased lung elasticity. As in pulmonary fibrosis, the lungs recoil inward more powerfully than normal. They pull harder against the chest wall. The balance shifts inward. FRC decreases. Small, stiff lungs, restrictive physiology. Decreased lung compliance, option A, means the lungs are stiffer, actually similar to increased elasticity. This would decrease FRC. Obesity, option B, abdominal mass compresses diaphragm, decreases FRC. Cephalad diaphragm shift, option D, exactly what obesity, pregnancy, and supine position cause, decreases FRC. Only decreased lung elasticity, as in emphysema, increases FRC. Understand the balance. Everything else follows. Question 10. Which anesthetic intervention directly increases functional residual capacity? A. Trendelenburg positioning. B. Increasing FiO2 alone. C. Applying PEEPD. Hyperventilation. The answer is C. Applying PEEP. Here's why. PEEP, positive end expiratory pressure, maintains positive pressure in the airways at the end of expiration. Instead of airway pressure returning to zero at end exhalation, PEEP keeps it elevated, typically 5 to 10 centimeters of water in routine anesthesia. This maintained positive pressure does several things. It splints the airways open, preventing small airway collapse during exhalation. It recruits collapsed alveoli, reopening atelectatic regions that formed after induction from the FRC reduction caused by supine positioning and loss of muscle tone. And it increases the resting lung volume, functionally increasing FRC. The end expiratory volume is higher with PEEP than without it. PEEP partially restores the FRC that anesthesia takes away. This is why routine PEEP of 5 centimeters of water, sometimes called physiologic PEEP, is commonly applied during anesthesia to maintain FRC, prevent atelectasis, improve oxygenation. And in patients with significantly reduced FRC, obesity, ARDS, pulmonary edema, higher PEEP of 8 to 12 or even higher may be necessary to maintain adequate oxygenation. Now, the wrong answers. Trendelenburg positioning, legs up, head down, further pushes abdominal contents onto the diaphragm, decreases FRC, opposite of what you want. Increasing FiO2 alone delivers more oxygen but does nothing to the mechanical volume of the lung. FRC is unchanged. Hyperventilation increases minute ventilation, eliminates CO2 faster, but does not change end expiratory lung volume. FRC is unchanged. Only PEEP directly and mechanically increases FRC during anesthesia. That is 10 questions, lung volumes and capacities. Your 5 things to lock in before you go. Residual volume cannot be measured by spirometry, requires helium dilution, nitrogen washout, or body plethysmography. FEV 1 over FVC ratio. Normal approximately 0.8. Below 0.7, obstructive. Normal or elevated, restrictive. FRC, air remaining after tidal expiration, your oxygen reservoir during apnea, decreased by supine position, obesity, pregnancy, and general anesthesia. FRC is greatest standing, lowest supine. Emphysema increases FRC via decreased lung elasticity. PEEP, the only anesthetic intervention that directly increases FRC, recruits alveoli, splints airways, partially restores anesthesia-induced FRC reduction. I'm Anesthesia Buddy. Stay sharp. See you in the next one.